recording for this meeting has begun.
So welcome one and all. My name is Jordan Baker Friend, and I'm with the University of Nevada School of Medicine, Office of Continuing Medical Education. And I'm here to welcome you to our webinar and introduce our wonderful speaker, Paul Snyder. He is here today to talk to us about pharmacology of marijuana. We are so very honored to have him with us today. Please note this slide here with our learning objectives and our disclosure policy, should you have any questions. And without further ado, here is the man himself.
Oh, thank you very much. Thank you, Jordan, Jennifer, Jean, University of Nevada School of Medicine, JTNN, Nevada Statewide Coalition Partnership. My name's Paul, and I have a master's degree in addiction studies from Hazelden Graduate School. I'm also a licensed alcohol and drug counselor in Minnesota and Nevada, and a preferred provider for the Nevada State Board of Nursing. So I'm coming at you from a treatment perspective. With treatment, my experience includes working with healthcare professionals, working with adolescents, working with students, just everybody from A to Z. I have experience in residential, intensive outpatient, and outpatient treatment. Today we're going to discuss the mental, physical, and societal effects of marijuana use and identify the current trends of marijuana use. So first we have to look at what is marijuana. This is defined as from the Nevada Revised Statutes. And marijuana is the whole plant. It's the whole weed. It's any part of the plant, whether growing or not, the seeds, the resin extracted from any part of the plant, every compound, salt, derivative, mixture. So when somebody says marijuana, they're not breaking it down to the individual compounds. What they're saying is the whole plant. So when we're thinking about that, you have to think about the willow tree or a rose bush. We're talking about a whole compound, complex organism. Cannabis sativa contains over 480 different compounds. 66 are termed cannabinoids. When we're looking at the cannabinoids, they're separated into the following subclasses. Cannabidiol and tetrahydrocannabinol are the ones that are getting most of the press today, so that's where we'll spend a lot of our time on these two areas. Cannabidiol, most abundant of the cannabinoids, thought to make up about 40% of the plant resin extract, has anti-inflammatory, anticonvulsant, antipsychotic, and analgesic properties. So it's kind of the balancing act with the THC. Thought to have anti-anxiety effects, possibly counteracting the psychoactive effects of THC, being researched for multiple sclerosis, fibromyalgia, epilepsy, and providing relief for chronic pain due to muscle spasticity, convulsions, and inflammations. So this has therapeutic potential, and this is being recognized as something that deserves more research, and the research is continuing to go on. Now we're looking at delta-9 tetrahydrocannabinol, or THC. This is the brain's chemical, anandamide. Ananda means bliss or joy. This brain's chemical is made to be delicate. It's made to gently impact the neurotransmitters to send messages throughout the brain. THC is similar in structure and allows the drug to be recognized by the body and alter brain communication. The way this works is it's interesting. THC actually attaches to the postsynaptic neuron. When it passes to the postsynaptic neuron, cannabinoids are released into the presynaptic and then hit the receptors. What this does is kind of like acts like a dimmer switch, where anandamide, like imagine just flicking on a light. You go to the light switch, you flick it on, and then anandamide goes through, gets that message, the light goes on. THC, as a dimmer switch, actually goes through and clouds the receptor system. Also, THC impacts GABA, which is one of the reasons that GABA is important is that it regulates the dopamine release. So the non-dopamine release means that more dopamine is being released, so that's that feeling of euphoria that comes along with THC. With this abundance of the neurotransmitters, we have to look at norepinephrine, and we're looking at the reuptake of norepinephrine. So we're having a flood of the chemicals that feel good, including adrenaline. This leads to euphoria, but then also there's a norepinephrine deficit, and the reaction to adrenaline then leads to a physical and mental drowsiness until normal levels are restored. So what is given or released must be made back up. This also increases appetite, reduces nausea, and may also reduce pain. We're looking at the cannabinoid receptors, which are located throughout the brain and the entire body, possibly more numerous than any other receptor system. These receptors control appetite regulation, peripheral energy metabolism, pain and inflammation, GI motility, secretion, neuroinflammation, and it's thought to be the largest receptor system that we have in the body. They're also researching and saying that we have a CB3 that's possible. But when you're looking at the receptor system in the endocannabinoid system, it's difficult to see where one receptor ends and another begins, especially in the brain. Now, it's scattered throughout the body. However, the brain is so clustered with the endocannabinoid system receptors that it's difficult to figure out where these compounds are going to go. We're looking at the 480 compounds of the marijuana plant that become over 2,000 compounds when combusted. So remember I started off the talk with thinking of marijuana as a compound complex plant? Well, think of it as the willow tree. We get aspirin from the bark of the willow tree. So if somebody needs their blood thinned, or somebody has a headache and they go to the physician and the physician says, okay, I'm going to have you try aspirin, the physician doesn't say, go out to my orchard, I'll help you cut out a tree and then mash it up and start smoking, and then possibly one of these compounds is going to hit the correct receptor. This is what's happening with the confusion around marijuana. The 480 compounds become over 2,000 compounds, and that's why we're having issues with an example of 3 people smoking a joint. One is feeling euphoric, kind of has the munchies, a little bit off balance. The other person's just zoning out, still feels pretty good, and can't remember anything. And then the third person is completely paranoid and freaked out. Why is that? All of their different receptors are being impacted differently by THC, so there's no consistency in what's being introduced to their system. So when we're looking at also smoking delivers toxins as well as potentially therapeutic compounds, this is from the American Lung Association. They report marijuana has 50 to 70% more carcinogens than cigarettes. When I'm showing you these slides, you have to recognize that the information that I have is coming from researched white papers and valid sources. When we're looking at the amount of information that's being given, the volume is substantially in favor of marijuana being benign. So we have to really look at where are we getting our research, where are we getting our information. So let's go back to the example. We have 3 different people. They're smoking the joint. They get 3 different reactions. Why is that? So let's take a tour around the brain real quick. We have the neocortex up to the prefrontal cortex. As you note, this is relatively new to the human experience. And we look at the brain development. Brain development starts with that animal brain, that small brain. Then it takes about the next 25 years to build up this through the limbic system. Prefrontal cortex begins to mature around the age of 25. So the limbic system is what is running the show, especially in adolescence. So we look at also what's happening in males when they're in their early formative stages or young adulthood. They're having a chemical called testosterone that's being introduced to them at the same time. So why do they do what they do? Why don't they have really impulse control? Why are they surfing on top of cars? What's going on there? Well, a lot of that has to do with testosterone. Females have estrogen and progesterone. So we have all different kinds of things happening to this developing brain, and now we're introducing a chemical that feels good and gives them an altered sense of reality. So what's happening when THC hits different areas of the brain? Right here, basal ganglia, that's for your reaction time. A lot of my athletes are really interested in this area of the brain, and they also are interested in the cerebellum. Cerebellum is about balance, coordination. It also deals with a lot of emotions. Nucleus accumbens, here's one of the problem areas. This is where the dopamine is released. So we have the ventral tegmental area, that's not on this slide, but the ventral tegmental area communicates to the nucleus accumbens and says, this action is good, therefore I am going to do it again. Splashes some dopamine up against the prefrontal cortex, and the prefrontal cortex says, okay, I'm going to do this again and again. So the person who has the munchies, look at that hypothalamus that's down in there. The person who has the munchies, when food is introduced to somebody who is hungry, they have a pop or a spike of dopamine of about 50 points. So if you're cruising around 100 and you get a spike of 50, that's substantial. You're going to do that again. Sex is about 2.25. That's the highest naturally producing dopamine release that we can acquire, and that's for the procreation of our little ones and keeping our species going. So all of this stuff is because we're wired this way. But when something impacts this area and says, okay, we're going to release this dopamine up against a prefrontal cortex that is not yet fully developed, it has no executive functioning to say, I'm going to stop this. It just says, this feels good. I'm going to continue to do it. So at this point, we have to look at our youth. We have to look at our adolescents and recognize that we're their surrogate prefrontal cortexes. We're in charge of making sure that they're taking care of themselves and making the right decisions. Hypothalamus, that's the sexual and increased appetite for food. Amygdala, remember our friend who is paranoid? That's the area of his brain that's being impacted. We have the hippocampus over here. This is charged with memory, but it's not really memory. It's more of a filter to tell us what's not important. So when we're looking at driving to work today, you have all these trees, all these plants, and the hippocampus is just saying filter, filter, not important, not important. Here's the problem with THC. When it impacts this area of the brain, it says nothing is important. I do not need to retain this. However, whatever is in front of me at this point is extremely novel. So that's why TV is such a great babysitter, because it just flashes. But if you're worried or wondering if this part of a brain is being impacted after somebody smokes a joint, have them read a couple of pages and then recite back to you what they just read. Really difficult. Brainstem, anti-nausea effects, spinal cord, altered pain sensitivity. I'm talking to one of my friends who's a chronic pain and addiction specialist, and he has this patient, and he's getting him off of narcotics and getting him onto a non-narcotic pain reliever. And so the person tries it, patient comes back in, and he says, well, how did it work? And he said, well, it sucked. It just took away the pain. So when we're looking at pain sensitivity, pain is also important because it's a way that tells our body that something isn't right. There's a colony or a group of people that don't feel pain, and we used to put them in an island. It's leprosy. They'd be chewing their tongues all the way through, or they'd scrape up against a tree, get an infection, and end up having severe consequences from that. So pain is good. We just have to recognize it, regulate it, and there's also ways of dealing with physical as well as emotional pain. Recognizing that both are real, that's where treatment works. That's where treatment comes in, or counseling. Schedule 1. The board shall place a substance in Schedule 1 if it finds that a substance has high potential for abuse, which marijuana does, and has no accepted medical use and treatment in the United States, or lacks accepted safety for use and treatment under medical supervision. So that's why we're in Schedule 1. FDA, AMA, ASAM, SAMHSA, NIDA all say the same thing. Separate the compounds, make the results reproducible, research and controlled safe studies to determine benefit to risk, be standardized by identity, purity, potency, and quality, provide directions for use, and include safe and reliable delivery systems. These are not unreasonable requests. Actually, I sold pharmaceuticals for a number of years, and we had 2 blockbuster pharmaceuticals that were coming out, and we did this study. It had over 10,000 patients. It was double-blind, multi-center, placebo-controlled tests that were rigorously studied, and we had some really good results. And so I'd take them out to the physicians in this area, and I'd say, look at this. This is a fantastic product. Try it with your patients. Consistently, the message back from the physicians was, well, how many reps do you have out there? Well, we had about 5,000. This is a big pharmaceutical company. Okay, well, I'll tell you what. You go out and you try your drug for a year throughout the world, and then we're going to find out exactly what that drug does, and only then will I take a chance with my patients. And I'll tell you what, I respected that. There's no way that you can really argue with that. That person's looking out for their patients, and that's who I want. That's what I want my doctor to say. So things to consider. What's the dose? Now think about when somebody's smoking a joint or somebody's smoking a cigarette. How do you dose it? Is it 1? Is it 2, 2, 2, 3? What's the strain? There are so many different strains available. It's difficult to see where you're going to get a specific strain, and then how does that specific strain impact the body? So we have that 2,000 compounds impacting the endocannabinoid system. It's going to be very difficult to figure out how any specific strain impacts the body. People are harvesting and growing their own marijuana. So how are they fertilizing this stuff, and how are they making it grow? How do you know? How is it standardized? When the FDA as oversight makes it possible for the recall of harmful drugs or contaminated batches and the dissemination of new information about drug safety, that's not in place at this time. No other prescription medication is smoked. Concerns remain about the long-term risks and respiratory problems associated with smoking marijuana. Because remember, we just added a respiratory event if you're recommending that somebody has marijuana, because at this point, physicians cannot prescribe marijuana. If you did want to prescribe marijuana, there is synthetic delta-9 tetrahydrocannabinol that's available. It's been out for a couple of decades. It's indicated for the treatment of anorexia associated with weight loss in patients with AIDS, and nausea and vomiting associated with cancer chemotherapy in patients who have failed to respond adequately to conventional antiemic treatments. So Marinol has been out. Synthetic delta-9 tetrahydrocannabinol, THC, has been out, and it started with AIDS and trying to find relief for people with AIDS. Now you see, we get into a situation where people bring out a young girl with epilepsy and say, this will help her, marijuana will help her with her epilepsy, or a veteran who has PTSD. This will help that person with PTSD. We have to make sure that the benefit is outweighing the risk. If the idea is just to have them feel better, there's many different drugs that will have them feel better. However, it's not responsible to say that this is appropriate care for this individual. However, there's a CBD-based drug recently created to treat certain forms of childhood epilepsy. It's not yet FDA approved, but it's available to anyone who fails to respond to any other treatment for free through a compassionate use trial. So this is free. People do not want to see that young child suffer. People do not want to see our veterans suffer. People don't want to see anybody suffer. But the idea is, again, benefit to risk. We have Sativex, that's peppermint-flavored mouth spray. It's being used in Europe. It's being fast-tracked through U.S. clinical trials, and that's for multiple sclerosis and treatment of severe neuropathic-related cancer pain. Here's what happens with identification cards. How did arguably the most intelligent people on the planet get to be the gatekeepers for marijuana? Well, times are changing. Here's what we got. If you're going to set up somebody with a registration or identification card for marijuana, you need valid written documentation from the person's attending physician stating that the person has been diagnosed with a chronic or debilitating medical condition. The medical use of marijuana may mitigate the symptoms or effects of that condition, and the attending physician has explained the possible risks and benefits of medical marijuana use. Here's the law. These are the approved conditions in Nevada for medical marijuana: AIDS, cancer, glaucoma, PTSD, cachexia, persistent muscle spasms, seizures, severe pain, and additional conditions subject to approval by the Division of Public and Behavioral Health. Before recommending marijuana to a patient, ask yourself the following. Is there documentation that the patient has had failure of all other conventional medications to treat his or her ailment? Have you counseled the patient, documented by the patient's signed informed consent, regarding the medical risks of the use of marijuana, at a minimum to include infection, pulmonary complications, suppressed immunity, impairment of driving skills, and habituation? Has the patient misused marijuana or other psychoactive and addictive drugs? This is where an alcohol and drug counselor can be helpful. You can do an assessment and an evaluation, pairing up with the physician to make sure that the person is at low risk. Do you periodically provide drug testing of the patient who has been prescribed marijuana, and have patients been excluded from being prescribed marijuana who are found to be using other illicit drugs? Who does the drug testing and by what means? So, other things to consider. Another thing to consider is talking to one of my physicians. A person is going in religiously for their pain medications. Every month gets that renewal script. Okay, so I recommend having some having a drug screen and it turns out negative. This person isn't using the pain pills for themselves, they're using it to sell. So we have a lot of different things that we have to consider with drugs. Is the use of smoked marijuana part of a study, and or will the monitoring of that use be under the supervision of an investigational review board? Have you carefully reviewed exactly which patients should be allowed to use this drug medicinally and for how long? And now here's more. Do you carefully examine and consistently follow up with patients who smoke marijuana as a medical treatment, including pulmonary function testing, evaluation of immune status, and the presence of any superadded infection? Just like any other drug, we have to recognize what does success look like and what is our exit strategy if in a timely fashion we do not see success. These are things that you come up with the patient so that you're both on the same page and you know exactly where you're going with this medicine or any medicine. Have you exercised due care in assuring the standardization of tetrahydrocannabinol potency content of the marijuana to be considered for medicinal use and whether it's free of microbial contaminants? So we're looking at purity there. Because marijuana is a federally controlled substance, has a system been established in the state to track all patients and their source of marijuana as with other controlled substances? Are you complying with such requirements? So now we're looking at electronic systems that have to be impacted or implemented. Will you be required to be licensed by the state or federal government? And have you shown knowledge, training, or certification in addiction medicine? Do you have demonstrable knowledge of the physiologic effects of marijuana, its side effects, and its interaction with other drugs before prescribing it? Again, that's where a counselor can come involved. Okay, so now we have different forms of delivery. We talked about smoking it. We'll go through and talk about different areas, but here's this. The legalization of marijuana has been being worked on for quite some time. This is Keith Stroop. He says, you'll use medical marijuana as a red herring to give marijuana a good name. Who has a better name than our physicians in our society? So we attach medical to it, we call it medicine, and all of a sudden, everybody, the vast population thinks, oh, it must be valid. This is just a twist in terms, and it's that red herring. No currently prescribed medicine was voted on by the public as opposed to rigorous FDA processes involving science-based facts. So it's political. We'll get into edibles now. Very potent, longer-lasting effects. Average beginner dose is considered 10 milligrams of THC. Candy bars have about 100 milligrams of THC. So you ask yourself, when's the last time that you had 10 milligrams or a tenth of a cookie? Oh, got a question in chat. What happens if it's used recreational? Michael, what happens if it's used recreationally or approved for recreational use? I can get into that. It's the same thing. The difference between medical marijuana and recreational marijuana is the label. It's all the same. If you visit Colorado, you'll see that you get the same thing. The prices might vary a little bit, but it's all the same stuff. User will feel the effects between 20 and 40 minutes after ingestion. Here's the problem with an edible. When people want to get high, they want to get high now. If they're waiting 20 to 40 minutes after ingestion, what else are they taking in between that time? Another problem is you're not able to stop your metabolism. If you're feeling too high after you smoke a joint, you can put it out. However, when it's in your system, you're along for the ride. If you want to get high and you're not feeling it for half an hour, some people tend to take more. Therefore, they're in a longer ride. This is what gets a lot of younger people's attention. When delta-9 tetrahydrocannabinol is being metabolized through the liver, it picks up 11-hydroxy as a byproduct. That can be detected in screening tools up to 5 weeks after ingestion. So if somebody has an FDA job or somebody has a job that's going to take a drug screen and they've been clean for a couple of weeks, then they say, yeah, I'm good. Well, you're about halfway there before it's not able to be detected. And it's stored in the fat cells, so it can continue to be detected even after time. Schedule I drugs, substances or chemicals, are defined as drugs with no currently accepted medical use and a high potential for abuse, like we were talking about before. Schedule I drugs are the most dangerous drugs of all the drug schedules, with potentially severe psychological or physical dependence. Some examples of Schedule I drugs are heroin, LSD, ecstasy, methqualone, peyote. Why do we say that? What's the big deal with that? We're looking at what is the availability of this drug. When we're looking at these other drugs, nothing has been embraced or politically and publicly accepted like marijuana. People cringe when they see heroin. Well, I'll tell you what, when somebody comes into treatment, we have our regular usual suspects. We have heroin, we have meth, we have prescription drugs, we have alcohol, and we have marijuana. All of those treatments are primarily the same. We have individualized treatment plans. However, they're all treated the same. Treatment costs about $1,000 a day. And while I was in Hazelden Betty Ford, we had a waiting list of people to get in. So what's driving the use of this drug? Price, availability, perception of risk, and public attitude. This is a currently marijuana that's being sold in the United States. Here's the problem with this. It looks like candy because it's disguised. It looks exactly like candy. Be careful about the brownies that you get in your office party. we have all this candy like laying around. Is this really for the 50-year-old guy who wants to get high occasionally? This is marketed to kids. Another thing is veterinary visits have exploded since this stuff has been introduced in Colorado. It's also happening out here. I'm talking to a younger person. They said, yeah, my dog got some of my stash. And said, well, what happened? And, well, my dog was always stupid, so I didn't really recognize any kind of problem, any kind of issue with it. But I was kind of mad because he got my stash. I was like, okay. Not a good message there. But then another young person that I talked to, their dog wasn't as lucky. Their dog was uncontrollably shaking and crying, lost use of its back legs, was whimpering around, trying to move around, was completely in a state of just turmoil. So when the person felt that they weren't high enough, or they were high, or a lot of the marijuana had left their system, or they were comfortable enough to drive, they take it to the veterinarian, and again, the veterinarian says it's being metabolized. All we can do is wait for it to go through the regular process. She said her dog was never really the same. Here's what's happening with products being sold in Colorado. You have gummies, 7 different types of cereal, 18 different types of cookies, soda, juice, 14 different types of juice, granola bars, chocolate bars. This is all about money. It's the perception of easy money. And that is the answer to a lot of the questions that come up with this industry, is what's the money, where is it coming from? Now we have dabs. Dabs, you might have heard about this in the news. This is where these explosions are going. Remember meth? Meth used to have a lot of explosions. Still having a lot of them, but they're just not getting as much press. But you separate THC from the other compounds by the use of butane. And so when people are separating these compounds so that they can get more THC, because dabs contain about 75% to 90% of THC, this is a very potent drug. My chronic pot smokers say that they avoid this. They've tried it once, and one person said it put them into an 18-hour psychotic event. They're really scared of this stuff. Here's the thing, too. The older people who are making the laws, they remember what the weaker drug was. This is a completely different drug than we had 30 or 40 years ago. A joint had about 15 milligrams of THC. Today the average is 150. How do they calculate that? Well, when the DEA makes a bust, take a little sample, they take it up to the University of Mississippi. University of Mississippi does calculations on it, and they can just see that the THC is continuing to go and grow. This is what dabs looks like. It looks like jelly at a county fair, or maybe peanut butter or salsa. Comes across really, really innocent looking. And that's the perception. If it's innocent and it's accepted, it shouldn't be bad. You know, in treatment, that's the thing that most of the younger people are worried about. One, am I in trouble? And after I get out of trouble, have I screwed up my potential? Or are any of the things that I did going to have long-lasting effects? And so without those two things, it's game on. Vape pen. Here you're seeing an explosion of vape pens all over. Now, cigarette smoke, although they say that marijuana has, or the American Lung Association says marijuana has 50 to 70% more carcinogens than tobacco. Tobacco is being frowned upon. Actually, tobacco's use has gone down from about 30% to around 18%. Meanwhile, vape pens and different ways of getting marijuana into the person's system is taking off. Talking to a younger person, what's the deal with the vape pen? Why do you like it? Oh, it's incredible. I can go out to dinner with my parents, go into the bathroom, get high, can't detect it, and come on back. You put dabs in this, you put tobacco in this, you don't know what that person is smoking. All you know is that they're hearing that vapor is more safe than smoke, and they can disguise whatever they want whenever they want it. Denver Post. Denver Post, there's an entire section devoted to telling readers about new strains, what the strains can be used for. Medical advice is given by a marijuana proponent, not a physician. This is where the physicians have to stand up and say, we're the ones who diagnosed, we're the ones who prescribed medication for the betterment of that individual. I go into a pod shop in Colorado, so I'm talking to this person and say, yeah, I have a little bit of pain in my back. What do you suggest? So, oh, here, come on over here. He shows me some marijuana. I say, oh, okay. Well, you know what? I want to get high with my family. We're going to go camping, and I want this to be a family affair. So what do you suggest for that? Oh, well, come on over here. This is more of a mild high. They're able to separate being stoned from high with the amount of CBD that's taken out and the amount of THC that's put in. So he said, well, okay, well, my dog's part of my family. I'd really like to have this be the complete family unit. What do you suggest? Well, we don't really recommend anything for animals. However, you could try this. You say, oh, wow, okay, so let's look at this. He diagnosed me without an exam. He doesn't have a medical degree. He didn't ask the age of my children. He doesn't know any conflicting factors of anyone in my family. He's even showing me stuff for my dog, an animal. All of this stuff is to sell. It's not being responsible. There's 88 strains for depression, 25 for PTSD, 23 for bipolar, Girl Scout cookies infused with marijuana for depression, no dosage, no screening, no instructions. It's just how do we sell this stuff? So what happened? We can look at what's going to happen here by looking at what happened in Colorado, or at least get an idea of what's going on so that we're not blindsided. In 2007 to 2008, early medical marijuana era, there was 1,000 to 4,800 card holders and 0 dispensaries. In the next 3 years, medical marijuana commercialization, that's the big name, commercialization, big money. 108,000 card holders and 532 licensed dispensaries. 2013 to present, medical marijuana commercialization and recreational marijuana. So while we have this medical marijuana, they're going to be fighting real hard to keep recreational out of it. Because once recreational comes in, they no longer have the monopoly. Then it's going to have to be open to everybody. Then it's going to be free trade like it is in Colorado. And right now, there's more marijuana pot shops than there are McDonald's and Starbucks combined. That's the next one. So let's look at what's happening to the youth. 8th grade youth in Denver, let's say 1 in 4, or 1 in 3, or 5, I'm sorry, 1 in 5, 8th grade. 9th and 10th grade, all right, we'll split the difference. We'll say that it's 1 in 4. By 12th grade, about 1 in 3 Denver youth has used marijuana. So what happens when these medical dispensaries were created? These are drug violations. And this is from the Colorado Department of Education in 2002 to 2014. You can see that the student suspensions because of drug violations has substantially increased. It's about doubled. This is drug violations involving law enforcement. Same story. What happened in Colorado when medical marijuana dispensaries were created for fatalities involving operators testing positive for marijuana? Well, let's look at this. Actually, fatalities have gone down. Thank you, police officers. Thank you, stricter laws. That's click it or ticket. That's more regulations. That's better laws and more scrutiny by the law enforcement. But when we separate those out and we look at fatalities involving operators testing positive for marijuana, that's about doubled. So you'll hear, since marijuana was introduced, fatalities have gone down. Yes. However, fatalities involving people who are positively testing for marijuana is doubled. That's what I mean about who's saying what, how are they saying it. Now, this is interesting. This is Nevada law. And it's saying that do not at any one time collectively possess, deliver, or produce more than 2 1/2 ounces of usable marijuana in any 14-day period, 12 marijuana plants, irrespective of whether the plant is mature or immature, and the maximum allowable quantity of edible marijuana. Well, let's break this down a little bit. 2 1/2 ounces. You can make 50 joints, good-sized joints, out of 1 ounce. So say you have 2 1/2 ounces. That's 125 joints. Let's say that you're selling them to your friends who are 18 and older. Well, yeah, it'll go $5 a piece. That kind of throws the allowance that the kids are getting out the window. Now let's go for somebody who's 17 and younger who can't have access like the 18-year-olds can. All of a sudden, that joint becomes a premium. You can get about $10 for that joint. 12 marijuana plants, you can make 1.5 pounds of marijuana out of one plant. So we take 1.5 pounds, that's 16 ounces plus 8 ounces, that's 24 ounces. You multiply that by 12, then you multiply that by 50, then you add any kind of money you want to it, and you're looking about big money, especially for kids. Medical marijuana, and that's what I'm talking about, big money. This is no joke. There's a lot of money. And there's no taxes being paid here when kids are selling it on the street or younger people are selling it. They're just pocketing the cash. And applicants under 18 must have permission from a parent or guardian. This is our regulations. So locations will not be within 1,000 feet of a public or private school. Locations will not be within 300 feet of a community facility. Watch out for this. They just had a big community meeting up at Mount Rose over at the high school there because they were thinking of putting a pot shop in there, and they're having some issues. This is supposed to be a medical marijuana dispensary. It was disclosed that on one side of the dispensary there was going to be a coffee shop, and on the other side there was going to be a deli. And this is all being built by the same person. So, you know, now we look at it, abuse, addiction, and treatment. Clearly some, but not all individuals are at risk of psychosis with exposure to marijuana, but it's not possible to identify at-risk individuals. Wouldn't that be nice if they had a sign saying, I'm at risk, I have a potential to be addicted to this? Well, we know addiction now has two different factors. It's genetic as well as environmental. Here's the deal. It's estimated that 9% of people who try marijuana become dependent. Those who begin using the drug in their teens have approximately a 1 in 6 risk of developing marijuana dependence. Okay, so we have 1 in 5 8th graders, 1 in 4 9th or 10th graders, 1 in 3 12th graders who are all trying it, and now 1 in 6 of those have a substantial risk of developing marijuana dependence. This is a DSM-5 substance use disorder. This is what I go through with people when we're trying to figure out where they fall on the spectrum today regarding their substance use disorder. So DSM-4 had 2 different criteria. It had abuse and dependence. For abuse, there were 4 criteria. For dependence, there were 7. What the thought leaders did was they put it all together. This is the APA. Put it all together and said there's 11 criteria. They did take out having legal consequences as a criteria, but then they added craving. And so if somebody has 2 or 3 of these criteria, then they're considered having mild substance use disorder. 4 to 5 have moderate substance use disorder, and 6 or more have severe substance use disorder. What is nice about this is when the professional is giving an estimate or a evaluation, it's objective. And again, it's a snapshot of where that person is right then, and it's also how honest are they being how honest are they being, as well as what kind of atmosphere has the person who's giving the test created. So you need a safe atmosphere to give this. But I put this into layman's terms so that they understand where they are. So taking criteria 1, taking the substance in larger amounts or for a longer period than you meant to, wanting to cut down or stop using the substance. I thought there was a question. 3, spending a lot of time getting, using, or recovering from the use of the substance. Cravings or urges to use the substance, not managing to do what you should at work, home, or school because of the substance. Continuing to use even when it causes problems in relationships. Giving up important social, occupational, or recreational activities because of substance use. Using substances again and again even when it puts you in danger. Continuing to use even when you know you have physical or psychological problem that could be caused or made worse by substance. And needing more of the substance to get the effect you want. And developing or withdrawing symptoms which can be relieved by taking more of the substance. I am trying to read questions as I'm doing this, so I apologize for the rocky review of the 11 criteria. Again, it's objective, and it gives you a snapshot of where the person is and lets you know where you have to start, where you can meet that person to help guide them through recovery. This is from the University of Michigan Monitoring the Future study. It goes from 1975 up to 2013, and it's showing daily marijuana use versus perceived risk of regular, I do have a question, okay, regular marijuana use among 12th graders. So you can see a perfect scenario here where when the risk is perceived as high, the use is low. When the risk is not perceived as dangerous, the use is high. So you can see how use is becoming more and more prevalent. Okay, hemp oil and cancer, JWF. Is that the question? Oh, okay. Oh, I'm not really sure about hemp oil and cancer. However, I heard, and I don't know the studies that are available. See, this is where it gets really gray. We have individual people who are emotionally involved with some portion of this business. And so I spoke with a cancer patient recently, and she said that she was going through her chemotherapy and she was struggling. However, she didn't use marijuana. She wasn't even considering it. Hemp oil, there's all kinds of different ways of infusing it into your body. So unless it's regulated, it's researched, it's studied, it's providing more benefit than risk, I would have a hard time saying that it's good for everyone or to make a generic assessment at this time. That's where the responsibility comes in to make sure we're doing more good than harm. And this is where the rubber hits the road. This is Nevada Treatment Episode Data Set. This is from SAMHSA. This is 2012, before marijuana was legalized. So we look at the primary substances. Again, there's meth, other opioids, that's your prescription pills, heroin, marijuana, and alcohol. So all the usual suspects. This is Nevada in 2012 from SAMHSA. This is not saying, oh, the United States is in an epidemic. This is our own backyard. When we're looking at the admissions for meth, meth is number 1 in 2012. Alcohol, number 2, and marijuana by less than 100 is number 3. Here's the thing. When somebody is going into treatment, you're taking that person out of their environment for about 30 days, and you're setting them up, and it's expensive, and they're taking a lot of time out of their life. They're discontinuing all of their regular jobs, their regular work, their regular lifestyle, and then you put them in treatment. So there's a substantial investment in treatment. When we look at marijuana, 12 to 17-year-olds, About 43% of the admissions for the number 3 in 2012 substance, primary substance, is marijuana. 18 to 20 years old, 13. 21 to 25 years old, 17. In this age gap between 12 and 25, when that prefrontal cortex is being developed, this is the largest reason for people to be admitted into treatment. Right there, you got about 73%. Here's what's fascinating. Let's break these drugs down, or the admissions, a little bit more. When we're looking at the people who are selling this stuff, those are the older people. It takes money to get into this game to set up a dispensary. They're not going to treatment for it because they're not smoking it. They recall what the old, weaker drug was, but they don't recognize what the new, powerful drug is. That's where these numbers come into play. Also, we look at different drugs. Heroin. Everybody's really scared of heroin. Look at the switch. Other opioids. Meth. Alcohol. Alcohol actually goes up here in the 46 to 55-year-old range. This is the deal. This is promoted to adolescents, for adolescents. It's the same thing as the tobacco industry did many moons ago, and they were successful. This is what's happening now. So with the responsibility of being a physician, with the responsibility of being the gatekeeper of marijuana, there's lots of things to consider, and I'm not saying never, but we're just saying hold it right now until that benefit outweighs the risk. Do I have another? No? Okay. Thank you all very much. Right up against the hour, so I'm available here if you have any questions, need anything involving drug or alcohol treatment, addiction, classes, whatever you'd like. Just please keep me in mind. And again, thank you JTNN, thank you University of Nevada School of Medicine and the Nevada Statewide Partner Coalition, and Jennifer, Jordan, and Jean.
Thank you so much, Paul. We appreciated having you with us today. So this is our last slide here today. I just wanted to point you towards our evaluations. You can claim your CME credit. That's going to be in the web links right there on the bottom left. So that's where you can complete your evaluation. And then in the bottom right, if any of the information you wanted to look at again, we have his PDF of the presentation, so you can look at it. It'll have his contact information should you have any questions for him. So that's the bottom right box. Go ahead and download that file, and you can have the PDF from today's webinar. Again, we so enjoyed the presentation. Paul, thank you so much for your time. And I just wanted to point you guys to a couple other resources that we have on our website. We have an opioids program that's happening on June 25th in Las Vegas. The Nevada Cancer Control Summit is on September 17th and 18th, and our Nevada Public Health Association Annual Conference is on September 24th and 25th. So you can visit our website. I'll go ahead and type that in just a second, so you can visit our website for anything else you may need. Sorry we pushed it right against 1 o'clock today. So go ahead and contact me at my email if you have any questions, or if for some reason anything is not working. I'll keep this room open for another 10 minutes so you can get the evaluation and the PDF, and then after that it'll be closed. Thanks again so much for your participation today.